So that's recording, and we will be able to share the recording on the website in the next few days. Please use the chat to say hello, introduce yourself, let us know where you're from and what you're hoping to get from today. And I will be quiet now and hand over to Andi for quick introductions. Over to you, sir.
Cool. Thank you ever so much, Phil, for arranging and organising this in the usual immaculate way. And thank you for everybody joining us today. My name's Andi Orlowski. I'm the Director of the Health Economics Unit. And today we're here to talk about systems and how systems work together and some of the challenges of system working. But first of all, to our honoured guest, the wonderful and lovely Esther, to introduce herself.
Thanks so much, Andy. So it's a real pleasure to be here this morning. So my name's Esther Nzenza. I'm the founder and CEO of a consultancy called Decisive that principally works with life science companies, helping in the way that they make decisions, particularly around evidence and access. Prior to setting up Decisive, I worked in big complex systems, i.e. the pharmaceutical industry itself, for around 24 years. So my experience comes from lots of different leadership roles and lots of different types of organisations, and now having the pleasure of taking a purview across lots of different decision problems and helping companies solve complex decision problems in practice. So I'm really looking forward to sharing our perspectives in different worlds today, Andy.
No, thank you, Esther. And I think your experience of, we'll talk about collaborative negotiation coming up in a bit, but I think that one of the exciting things that we talk about often with population health management and some of the work we're doing around addressing inequalities and looking at these wider determinants of health requires systems to work together. When I first started working at NHSE, I worked in new care models, and then as we were working those new care models, one of the models that we were looking at and that has been adopted were these integrated care systems. First of all, they were called accountable care systems because we stole it from the US. Then someone tried to sue us because they thought we were changing the English system to an American system. So we tricked them by changing the A to an I. They never knew. And then the lawyers stopped and we had these integrated care systems. But the spirit was the same. The idea that healthcare only represents or only contributes 20% of your health outcome, and therefore 80% of your health outcome comes from other things, these wider determinants of health. And so the idea of integrated care systems, what they saw in the US, was that by getting the healthcare systems to work with other providers, and in England, that works more closely with local authority, to work with environment, treasury, justice, as well as, of course, those arm length bodies, social care, community care, and beyond, to work together as a system to address those wider determinants was a key bit. And so the Hewitt Review was very much about that, even though no one cares about the Hewitt Review. But sadly, it's a great review. But one of the things that we've seen with ICS is that it's this great big hope, this kind of this movement. But Hugh Oldwick, so the Director of Policy at the Health Foundation, wrote a great paper on the impacts of collaboration between local healthcare and non-healthcare organisations. And it showed that there is very little evidence to show that system working changes any outcomes for patients whatsoever. And so, of course, this is a bit of a bummer for ICSs when you're trying to work together. And then there's another great paper by Ungers, who came out soon afterwards, who said that there's a huge, there are huge issues to get past, which included faith or lack of faith and trust in these different organizations. So as Hugh talked about things like motivation and purpose, governance and leadership, resources and capabilities, relationships and cultures, what we found out is that there has to be lots of collaboration and negotiation between these organizations. And I thought it'd be really exciting and interesting to hear from Esther today about how she uses collaborative negotiation in her world and to see if that may be appropriate for our integrated care systems and beyond. So Esther, collaborative negotiation.
Thanks so much, Andy. So I first encountered the skill set of collaborative negotiation when I was working in industry, and I was fortunate enough to attend a training course which I often describe in retrospect as changing my approach to negotiation forever. So, and this was with a wonderful gentleman who I'm now fortunate to collaborate with, called Charles Barker, who was part of the original Harvard project on negotiation. and has worked across so many different spheres. So healthcare being one of his areas of specialty, but he also negotiates in humanitarian settings and deals with high situations of conflict. So his learnings and points of expertise, I think I would regard myself as a student of this discipline as opposed to the expert, which is the title that I would very much reserve for Chuck. But it's a discipline that I've studied pretty intensively ever since. And it's something that we apply routinely in our consulting practice, and that we also train and coach organisations on around the world. So negotiation might not be an immediate word that you'd associate with system change, but negotiation isn't, of course, just the process of buying a carpet or buying a car. It's any task of persuasion. And system change, of course, is underpinned by micro decisions and persuasions that move us towards a common goal. The whole principle with collaborative negotiation, as opposed to more positional negotiation, so positional negotiation being us bartering for a rug in a souk somewhere in the world, but rather collaborative negotiation is the process that also regards the relationship as being important. So rather than I win, you lose, Andy, collaborative negotiation is set up to say, well, actually, is there a way that we can both benefit from making a decision well together? Is there a way of aligning our interests, the things that we want to achieve, and identifying as many options as we can that will satisfy our different and in some cases overlapping interests sufficiently? So to give you a little bit of the theory, collaborative negotiation basically follows 7 key elements. They're not linear, so you have to imagine more of a kind of integrated spiral when we're thinking about this. But they broadly divide up into 3 macro tasks. And the first task of collaborative negotiation is to figure out what the value is and actually to identify ways of boosting that value. So every decision that we take, every task of persuasion that we deploy is done for the reasons of assigning value. And creating and allocating that value is something that we do all the time. I find myself using these skills to very variable degrees of success with my children, for example, when it comes to making selections for dinner or whether or not to do homework. But of course, they're transversal through all aspects of life. And when we think about creating and allocating value, there are 3 of the 7 elements that really fit under that heading. The first is interests. It's figuring out what matters. So what matters to you in the decision that we're taking or the change that we're implementing? What matters to me? Where are our interests the same? Where are they different? And are there interest areas that we can bring closer together through good discussion and debate? So figuring out what's important to each of us at its heart is the first step in creating and allocating value. The principle of collaborative negotiation then really drives us to think about creating options. So in crude terms, this is about making the pie of possibility as big as we can so that there's more value to allocate. So rather than looking at it in a very system minute way in terms of what do I need to win, it's saying actually what are the many different ways in which we could implement this change, this shift, this decision that will ultimately satisfy the interest that we have. It's a highly creative exercise. I think we tend to think of it as kind of brainstorming or idea storming. It's this concept of making as many different what ifs as we possibly can. Not all of them will be workable, not all of them will be feasible, but we shouldn't hold ourselves back during this phase of co-creation. And then we need to apply the lens of fairness. So again, in collaborative negotiation, this is termed as legitimacy. So it's the sense of how do we figure out what's fair? Because you'll be coming to a decision or a change with a view in your mind as to what fairness means. My standards and objectives and criteria may be different. So together it's about figuring out some objective criteria by which we can assess fairness, so i.e. legitimacy. And in some cases that might be legal frameworks or standards, it might be past precedents, it might be prices if we're back to buying the car. But again, it's figuring out that point of legitimacy that we can both look at and agree is reasonable. And then we use that to assess those different options. So based on this big table of possibilities that we've created, what's legitimate, what's fair, what can we objectively say meets your interests and meets my interests? And then we begin the process of the second task, which is choosing wisely. So again, I think one of the transformational things for me in my journey of learning about negotiation is figuring that the objective isn't always to reach agreement. So it's about making a wise choice. And negotiation and change management often comes down to this balance of wisdom. So it's very apt that you have an owl behind you, Andi. So in terms of choosing wisely, the first thing to do is to know what you'll do if you can't agree. So you've probably heard the term BATNA, best alternative to a negotiated agreement. And this is the sense of actually, well, if we can't get to consensus, if we can't reach an agreement together, what can I do instead? And very simply, I remember this using the first letter. So O for options are things that are on the table. They're things we can discuss, we can agree, we can potentially activate together. Alternatives, beginning with A, away from the table. These are the things that I could choose to do instead of making an agreement with you. So having a good sense of what your alternative is, being able to discriminate and identify your best alternative gives you tremendous strength and grounding in any negotiation or process of decision making, because it helps you to understand where else you could go. And actually, when I'm working with companies and teams on figuring out their negotiation strategy, helping them boost and bolster their best alternative is actually a really key part. Because ultimately, you shouldn't select any option unless it's better than your best alternative. So the better your best alternative, there's a lot of betters and bests there, the harder it is to actually make a wise choice and select the right option for collaborative outcome. So getting to understand your alternatives, figuring out what your best alternative is a really key step. And then things have to be things that we can commit to. So again, we've had our wonderful co-creation creative exercise. We've figured out what's fair. We know what our alternatives are, but now we need to have a good process and we need to have things that we can actually commit to. And I'm sure this is something that in NHS life is an incredible consideration. So is it realistic? Is it sufficient? And can it be operationalized with what we have? Or do we have the skills and capabilities to evolve to enable it to be operationalized? So it's figuring out, can we do it? So are we in a position, both from a decision rights and an execution perspective, to be able to make that selection? And then finally, as I mentioned at the beginning, the process of collaborative negotiation regards the relationship as important. And relationship is one of the 7 elements. So very rarely in life or work do we have a singular negotiation where we can come together, agree or disagree, and never have to interact again. So a good negotiation, even if it doesn't reach the positive outcome that we want, should be one that doesn't weaken the relationship between the negotiating parties, but in fact can strengthen it. So if we're listening well, we're understanding one another's interests and perspectives, we're coming to the table together to try and find the best possible outcome, then that can only secure and strengthen relationships. And that communication, I can't underestimate enough. I'm not sure in NHS life, Andi, I'm looking forward to hearing your view, but so much in business is done away from a physical table. And particularly in the era post the COVID pandemic, there's much more negotiation done virtually, done in writing. We're trying to manage system change through Zoom, and the many complicated channels that can stand between us and good communication. So having a really good structure and a way of thinking clearly, of listening actively, and making sure that we're communicating with the purpose of being understood, not only heard, is absolutely fundamental. So collaborative negotiation, creating and allocating value, making wise choices, and remembering that the relationship matters. So focusing on building rapport. And yeah, a very whistle-stop tour, but I hope an interesting glimpse into collaborative negotiation.
No, thank you ever so much. And I think one of the things that we have done before and is use multi-criteria decision analysis. And I know we've spoken about this as well as a way or a means of trying to, again, attribute a value to a thing. This idea of creating a list of criteria that people can, again, they have an interest in, they think then we can attribute a value to those, and then see on how and prioritize those values. And there's some wonderful work done led by Sophie Hodges at the Health Economics Unit, working with 5 ICSs using an allocative efficiency tool, something that we use called STAR. But effectively, it was an MCDA tool that got stakeholders in the room. And it was that whole bit about, as you say, building relationships where sometimes these people had worked together for years and maybe not met, or maybe not met for years because of COVID and the pandemic, trying to get their people, like people from environment, the local authority, planning to work with people from charities, the clinicians and medics and finance, and trying for these people to come together to make, agree. And they did 5 ICSs and made some, significant changes to the care pathway and outcomes. But of course, one of the big challenges you have with active efficiency and negotiation that way is something has to be turned off for you to be able to spend more money with the finite resources. And so one of the problems we often get when you talk about relationships and I think that I wholeheartely agree, a lot of negotiation happens away from the table, but it's often about protecting vested interests and looking after your bit. And when I think we mentioned before, in COVID, when we were all aligned, we all knew what the goals were, we all had the same interests, we all knew what good outcomes were, everyone was aligned, and of course we had lots and lots of money, so it wasn't a big problem. But when you're in financial crisis, as the NHS starts to really feel the bite this year, people become very, very protective of their organisations and their vested interests. Where can collaborative or negotiation help when you've got people who are, again, starting to hide their homework, not share their sweets, and make things as difficult as possible to negotiate?
It's a great question, Andi, and I think maybe we can look at this in a couple of different ways, because there's certainly the domain where the skill set of collaborative negotiation can be hugely supportive in things like building consensus, building a platform of shared support, making sure that those diverse perspectives are really recognised and valued within the decision-making process, and ultimately increasing the legitimacy of the decisions that are made. But I want to come back to a comment that you made first around actually having a shared goal. And again, collaborative negotiation isn't necessarily only a process for agreeing an outcome. It can also be a process for agreeing a process, for want of a better description, or for aligning actually on a shared goal and a shared incentive. And certainly I see it within corporate life that the alignment of incentives is absolutely crucial to system change, particularly when you're looking for something meaningful and sustainable in the context of a complicated system. So if you've got misaligned or conflicting incentives, it can really get in the way or even reverse progress in key areas. So getting those incentives aligned first, I think perhaps would be something we'd probably all advocate for, although I recognise it's not as easy as that in a system with adjacencies such as the NHS. I mean, how do you tackle that today?
I think, one of the big parts of using, multi-criteria decision analysis for us, again, is the one thing that we've all got in common, nearly all of us, are trying to improve the outcomes of patients. So that it's very easy to start to align around that goal. I think most people in the public sector feel very strongly about inequalities, and we understand that these inequalities are baked in through these wider determinants. It's very rarely is it just about access alone to the fact that I can afford to get a private GP appointment where they can only afford to go to the local practice where they may have to wait weeks. Those kind of jarring bits around access are one part, but there's a huge amount baked in around, as I say, the environment. And I know Phil will love me for this when we start talking about elements like boilers, double glazing, simple structural things that can make a difference. Is he pulling a face?
Yes.
Oh, I think it's that's sorry, it just flashed up. I'm sorry, Phil. But this idea that the system is very, very keen to align around addressing those bits. So if you can start to bring those stakeholders and to trying to explain to them that this is the ultimate goal, very few people will stand and say that's not for me, that's why I'm not here. And then we start to talk about small changes. And I think that the great success that Sophie and her team had was, it's not saying this big left shift. And the work that we do with the Healthcare Financial Management Association is that you're coming to Rob Hospitals, Andi, and give it all to primary care or all to community care, local authorities and prevention. And you say, well, actually, it's small percentages. And I think that the team have shown that by moving small amounts of money on prevention that can have an impact in year, makes a change. Because of course, one of the problems we have, Esther, is that if you reduce the numbers of people going to A&E, you don't save any money. A&E is still open, all the costs are still there. All you're doing is maybe reducing the queue for by half an hour, or potentially even less, because you've taken out those with COPD or other ambulatory care sensitive conditions. So some of the incentives are around addressing inequalities, patient outcomes, everyone's bought into. Some of the wonderful outcomes, though, we don't recognise because of these fixed costs that are related to running care. And so, this is where we have some, potential, vested interest. Some of this bit. Well, if I have to give up £1 million, that's 70% of that is staff wages, and that means that's 700 grand's worth of my colleagues, friends, people I've worked with for years that you're now asking me to give up every year. How does that happen? And so it's those bits that we have to deal with through your collaborative negotiation, and as you say, in this idea of aligning incentives. Have you seen success for those kind of tricky problems?
I think it's a really tricky area, and I think interesting listening to you. There's a definite difference behind aligning incentives that are about the outcome and aligning incentives that are around investment and the financial inputs. I know there's been much debate for many, many years around shared budgets and the flexibility that might bring. But of course, as you describe, that has a very real individual impact in some cases. And I think where you see mistrust or adversarial relationships emerging, it's often where there's not a full disclosure or trust in being able to share these types of concerns or interests as we frame them in collaborative negotiation up front. And I wonder how different that conversation would be if it were able and allowed to be focused solely on the outcome that you're aiming to secure, and then have almost away from that table the conversation on the resource allocation. But no, interesting. What do you think?
Well, no, I just say, and of course, outcomes are really rather tricky in healthcare, because some wonderful work you can do will stop people getting diabetes in 30 years. Or stop kids from having heart attacks in 50 years. And so you can't pay out or incentivize around outcomes that may or may not happen, sometime after your tenure. So when you're looking at the logic models to build this, you've got your resources and your inputs, and then you've got your outputs. So we did more visits, we put in traffic calming measures. Do you pay out on outputs because they're a lead marker for success, rather than a lag marker for success, like the good old days in the pharmaceutical industry? Do you pay out on sales when it's too late, or do you pay out on the sales force visiting doctors, by doing meetings, by doing things that hopefully there is an evidence base to show that they lead to success? And so it's those kind of trade-offs. And in healthcare, this idea that you do preventative measures by putting in boilers, by doing double glazing, traffic calming measures, and to stop people from coming to hospital. These are lag markers for success. And of course, they still may come to hospital, but maybe less, maybe for other reasons. And it's how you balance those, I think, is the constant. So can you get incentives or interventions that pay out quickly? So can they have an in-year return because of the way that we run our budgets? And so that's great. But of course, for most prevention, it's much longer than that. So how can you maybe start with something like, taking down carpets at home and grab rails, versus a wonderful campaign about good diets and educating children on how to eat and how to cook, so that they can eat better at home, and then hopefully as adults go from there, or make sure they get the right GCSEs and A-levels, and because better education leads to better health outcomes in the long run. These are all kinds of these kind of big, I suppose, gaps in those outcomes that can be a real challenge.
Yeah, completely hear you. And I think it's back to the old kind of 1980s management adage of you can manage what you can measure. And that is, I think, a perennial challenge. I guess we're operating in times where the fluidity of data and inputs has exploded exponentially in terms of our possibility of being able to measure different things. The challenge is figuring out which of those things are important lead indicators of those bigger changes. But yeah, there's no magic answer to that, I don't think, unfortunately. But hopefully, collaborative negotiation and the skills of really seeking to understand and bringing diverse perspectives to the table can help us to at least narrow down the possibility.
And if it helps you populate that logic model, because again, the one thing you're not going to change is that you're preventing outcomes that happen down the years. So what is a good lead marker you can pay out on that would be appropriate, that we all think is adding value, that we all think is sensible, like boilers, Phil, and things like this that can make a real difference to someone's home. And if I say it once more, are you just going to turn me off?
We're going to get switched off.
I'm going to mute you.
Yeah, to say, look, I've got a whole deal with that famous boiler company that I should have the advert in the background. But yeah, it's this idea of finding appropriate levers that that, as you say, when you're working together in these teams, do the clinicians, the medics, and our finance people in secondary care agree with the patients, the carers, people with lived experience? Do they agree with the arm-length bodies that one incentive, I won't mention it, a preventative thing is as valuable or worth measuring versus these? And of course, many of them aren't mutually exclusive, and you can do little bits of different ones to be able to see. And then we come back to, I think, a really, really important part about measuring and seeing the effectiveness. Through collaborative negotiation, how do you build in evaluation? How do you make sure it's working? What are the kind of the feedback loops that you think are important in this?
I think that's all about establishing and agreeing a good process, not just for the classical bit that we consider to be the direct negotiation, but the implementation of the decisions that we take jointly. And again, outside the pure model of collaborative negotiation that we've discussed today is the concept of regular review and discussion. And again, if the decision that we're making together is important, if the relationship between the stakeholders is important, why would we not be checking in regularly to make sure that the assumptions that we made together, that we jointly considered to be legitimate, that we jointly considered to be actionable and something that we could commit to, were not being pulled through? But it's something in life, in the world, in business and in health, I'm sure, that probably the busyness of day-to-day life stops us from doing as routinely as we should, in terms of applying that kind of retrospectoscope to say, well, this is what we thought. Did it hold? Is the decision that we took still valid? Do we need to re-challenge ourselves on whether our interests are being met, whether the source of legitimacy or the proof point has shifted? And what do we do as a consequence? So, but I'm fully with you. I think we should never regard a negotiation as a singular event. And one of the other great lessons that I've had over my professional career is also, when does a negotiation begin? So does it begin when we sit down together with all of our information to actually start having the discussion, whatever it may be, or is it in all of the steps that run up to that? So the way that we shape the environment in which we're making these decisions, the way that we think about what it is we're trying to achieve, the way that we think about who to involve and how to release that diverse perspective within the decision-making process. It begins far earlier than actually we usually consider.
And again, I think you make a really good point, and how this then, when you're talking about when it starts, about how you then prioritize those goals, because depending where you are, so how do goals make a big difference in and setting goals make a big difference when you're kind of doing collaborative negotiation?
So there's a fine line between having a goal or an outcome and having a fixed position. So traditional old school negotiation would set you a fixed position. So I want to buy a car, and I want to buy a car for £7,000. Those were the days. But that of course, is a fixed position, and I'm not moving from that. I'm not moving from that under any circumstances. Whereas perhaps a more useful goal under collaboration is, I need to be able to travel fluidly between A and B. I've got a limited amount to spend, but I'm interested in seeing what I can do that's sustainable, that's environmentally friendly, that is good for my community, that's good for me, good for my family, and is reliable. And that's perhaps a very different set of decision criteria or interests than that singular singular fixed position. But you only get to that through asking really good questions and actually really going back to what we've talked about on our previous webinars together, really framing the decision problem well. So do we know what we're trying to solve? Do we know why it matters? What's important? What's important to all of the different stakeholders? And actually, therefore, what would a measure of success that we can all align to and agree with look like? Does that make sense?
No, 100%. And I think that for us, I know we talk a lot about problem formulation, and one of the key things that we need to ask is, what's the problem we are trying to solve? Is it clear on what we're trying to achieve from this? And then, of course, because when you're starting to look at these kind of wider groups, these systems, does everyone agree that that is the scope? And so what is the problem? So this idea that we think the problem is inequalities, is that true for all of these other people? Actually, it's not inequalities, it's the variation in outcomes for us, even though that may be led. And it's that idea of really understanding what the problem is, then trying to work what the scope is when you're looking at this, because of course there's with systems, and when you're trying to align all these different goals, all these different approaches, you have loads of people who want, it gets broader and broader and broader. And what you're trying to, when you're trying to, COPD is a big disease area. Some of the others are very big, but you suddenly can end up trying to boil the ocean, and having the right time, the right amount of effort behind it becomes a real challenge. And then how do we break down the problem? How do we break down a project? And one of our final questions that we always ask is, why isn't it obvious why we can't deliver this? What's the thing? Why have you come to us? Question. Why do you need to use collaborative negotiation to fix this problem, or a different way? Is it because because you've failed before, and if you did, why? Or do you think it will be particularly tricky, and why? So no, I think it's that problem formulation step. And I know many of the analysts who are watching or may watch this later, have been asked to create dashboards. Oh, I need a dashboard, Andy, that will help me better understand this. No, dashboards don't really change anything. What's the problem? And because your problem, very few problems are solved with a dashboard. What are you trying to get to understand? And then how can we kind of help you with that? So that's that again, starting to pick apart why they're trying to negotiate, plan, change, and to be able to better understand the problem in the first place. So no, I think that's really, really important.
Absolutely, and it starts at the very highest level, doesn't it? Excuse me, I think that the term North Star is probably quite overused in our popular culture, but it is this concept that if we all know where we're pointing, then we can make sure that every micro decision along that path points in the same direction. And that's how we really enable change within organisations or systems, is by knowing where we're going. And again, that alignment of goal, that alignment of incentive, that alignment of process, of knowing how we judge success and fairness at each step is fundamental to system change, whatever the system.
Yes, no, and I think it's this, I say this idea, and I loved your idea that negotiations aren't a fixed point. This is a constant moving thing, that again, goals and all of these things may be changing. And when we start a project, they may have been asking for one solution or one way of doing things, but actually they're now looking for something else.
Yeah, absolutely.
So thank you ever so much, Esther. So I think we can open it up, if that's okay, Phil, unless there's anything else that you want to talk about, Esther. But I think that we've covered our homework, haven't we, Phil?
I hope so.
Absolutely. Yes. Thank you very much, both of you. It was very enjoyable, and even the mention of boilers.
Good. Well, I try my best. I didn't mention toe fungus.
No.
Happy. So, but anyway, on to yeah. Any questions?
Or any points to add? Yeah.
Well, it may be very quiet today, Esther.
Oh dear. We'll have to make up questions of our own then, Andy.
Yes, yes.
So maybe I'll ask you a question.
Okay.
And maybe other people on the line might have a perspective on this as well.
Yes.
But within a complex system like the NHS, how do negotiations happen? What negotiation training or support do people within the NHS actually receive?
So I think, to be fair, a huge amount of how we do things is base things on what we did in the past, and there's a big chunk of sadly of work and how the NHS progresses is that well we did this before, so there will be a small variation either up or down on previous years, and so therefore trying to change substantially how we will address things. So this idea of moving to wider determinants, the work that Sophie led, there wasn't a single person in the room who said this is rocket science, this is new, I didn't know that this was news to me. They all knew it was there, but what it did was coalesce people around a problem and to get them talking together, to get stakeholders in the room. And it's that whole relationship bit that was really, really important. Lots of negotiation, I think, happens between people who've known each other for many years and have worked systems for years, and it's just kind of done somewhat informally. And yes, there may be some analysis to back up the situation, but as I say, many of the stuff, or much of the stuff that it's showing, is already known to be true, and it's just there going, but is there some nuance there? Is there some change? Are there amounts allocated as part, or the resources allocated as part of a negotiation, or these informal negotiations, appropriate, or is it more biased because of relationships? Great, I need to give Esther this money because I know that she'll solve the problem. And again, it's this idea of I trust you, I have more faith in you, versus other organizations, which, and again, as a system, those other organizations should warrant additional revenue or resource. So again, it's that balance of trying to break some of the existing relationships. And again, many of these people have worked together for a long time. Sometimes it's a very positive thing. Sometimes it's a very negative thing because there's a lot of grudges that can be held over time. And it's so I think that for us, a whole load of work is being done behind the doors. And I think that's why things like MCDA, getting patients involved, carers, people with lived experience, opening up to other groups and being very transparent about it has a very, very positive effect. And I think that the systems involved with the STAR work, I think have hopefully got a new way of thinking, new relationships. If the very least they got out of it is knowing, I know Phil's the chap who I've been speaking to. He was really lovely at that meeting. I know I can just ring him up now. I don't have to send a very formal email. I don't need to do this bit. I don't need to do that. And so I'm hoping that by being more human and bringing people together, I think it makes them a bit more sense. So fingers crossed that we will move to a more transparent piece. And just to say, sorry, Phil, there's a whole load of work around decision quality being done. So not just by our team, but led by the strategy unit too, about how system leaders make decisions. Because a lot of decision making, because there's so many external variables, means that you can make a really good decision based on some great information, but because of something changes, you have a very poor outcome. And the same way that you can make a very bad decision, but because of market changes or variables, it looks like it was a very good decision. And so how do we start unpicking how to make good decisions? And everyone knows good decisions are never made in isolation. You need lots of varying views, and you need people with very disparate views to be able to help negotiate and talk, which is why most leadership teams in, even in our organization, a small organization, we're trying to get people with different views who are going to sit there and discuss and go from there. So no, I think it's a real challenge. But as we know, lots of the world goes round because of who you know. And that, certainly when it comes to public money and trust, may need to change. Phil.
I don't know if you've seen the chat, folks. There's a question there from Louise, but before you get to that, I just want to say, in a previous life, I think the problem was always there was so much protectiveness around budgets. Everybody was insanely protective over the money that they had and did not want to, if there was an excess, share it. And I don't think even if they could, they knew how to. They had no way of knowing how to reallocate that money if there was some left. And I also fell foul a number of times of very siloed thinking. Somebody would say, I want this, and then go all the way down the process of trying to get it before actually involving anybody else. And when they did, it was like, well, we can't do that. Or, we need to go back and get X, Y, and Z involved, because otherwise this is going to fall flat on its face horrifically.
Yeah, well,
So,
and this is what Unger mentions in his paper. There are lots of hospital trusts who have external income outside of the NHS. So some very large trusts make a huge amount of money from the funds or the charities. They have a huge amount from academia and research. So 50%, 2/3 of their income can come from without the NHS. So if they were to make a surplus as part of this, there's examples of trusts starting GP surgeries and funding GP surgeries and buying GP surgeries around the trust. So this is, and rather than funding primary care or giving a surplus back to primary care and letting the CCG do this and for them to decide, the trust, again, there's lots of words of trust here. Sorry, the acute hospital may be taking over primary care and them owning it because they don't trust or have faith in primary care themselves. They control that budget. It's their stuff. I will put our people in, the people that we're happy with, to be able to manage primary care. And where in a proper trusting system, it may be slightly different. And so, and again, it's how they can move money, what's appropriate and what's important. But it's a very important point, Phil. It's very difficult to move money in the NHS, and it's very few finance directors are going to get a big pat on the back if they're seen to be giving loads of money away to different people when their trust is falling down, can't employ enough people, have a long waiting list and everything else. So what can they do with these surpluses?
To Louise's question on how can life science industry work with the NHS to help to make positive changes, I think we covered some of that already, but you guys want to have a go at that one?
I think it's a really important question because, again, the kinds of challenges and decision problems that we're talking about here are not isolated. They occur across every ecosystem of every complex organisation, whether that be the NHS on a vast scale, or whether it be the learnings within organisations in life sciences and technology. And of course, there are decisions where we can jointly come to the table to make recommendations or negotiations that have mutual gain. So I think it is an important facet to explore. But Andy, where do you see this as being relevant from your perspective?
There are loads of skills that that external agencies have, and of course, lots of the time in the NHS, let's start again. I think that there are some external consultancies that have a bad reputation in the NHS, and they may be the KPMGs, the Deloittes, and these other people who may get £1 million contracts for not doing a huge amount. There are a whole load of partnerships that we've seen with industry, and we looked at the partnerships through COVID. We looked at the partnerships through joint working agreements and other bits that pharma do, often relatively small, working with small areas that can have a profound difference on patients and getting them access to appropriate treatments. And then there are organisations like yours, Esther, that beyond, and I know, Decisive does a lot more than collaborative negotiation. I don't want it to be pigeonholed for that, but it's the fact that you have a great understanding of these kind of skills, and it's that external thinking. And we said good decisions have to be made from a broad pool. You can't just have one way of doing things. So we, I think, have had some good success with multi-criteria decision analysis in helping systems make decisions. But what other ways of doing it? And I think it would be really exciting to see integrated care systems using collaborative negotiation as a way of making decisions to move resources rather than stuff. So, to me, there's loads of great elements from MCDA that's already in there, and there's additional bits on top of that. And so would there be ICSs out there willing to have a go and to see if this works? Because I say there's very rarely is there going to be one single approach that will solve everyone's problems. So I think that this diverse thinking, the new ways and new approaches, and saying, and knowing that they can be flexible and to fit the problem, I think would be really, really important. So no, I think there's definitely a role to play. And again, it's finding people who'd be interested in trying this.
Exactly. And I think it is about finding those transversal skills, so things that can be applied in multiple settings and where we can share learning. And again, do it with a common goal, which is, I think, where this all began. But no, I've really enjoyed the discussion, Andy. And I think, again, it's great to explore how our different worlds are often more similar than they seem different.
Yes, and it's funny for those who don't know, Esther and I used to work together, and I think that our careers may have diverged, but yet there's still so wonderful, wonderful commonalities in much of the work that we're doing there.
Absolutely.
But, thank you, Phil. Any other questions? Do we get to have an early cup of tea?
You do get to dash down for an early cup of tea. So I think, yeah, there's nothing else in the chat. So I will say we can leave it there. I'd just like to say thank you both, and especially to Esther for joining us this morning. It's been really, oh, Tom has decided to, last minute question there. So how could legislation potentially help drive the work of people supporting decision makers? Oh, if you were a new incoming government, what would you change?
Oh, that's a big question.
It's a loaded question.
So, Tom, is this one of your kind of Wes Streeting? We should get all managers chartered in the NHS. They should be professionalised and make sure. So I think that there's obviously a big question about decision quality and how system leaders should be accountable for the decisions they make, and how easy it is for people to be able to move across the NHS. So this idea of how can we help to better support them to make the best possible decisions, stuff that analytics, collaborative negotiation, all these things can do to help support those. And I spend a lot of time at AFA talking about the professionalisation of analysts, and we know that we have some amazing analysts and across the NHS, but those analysts are responsible for moving billions of pounds of money, and these just aren't the finance. These are people who are the performance analysts, the general analysts who help run trusts and manage those. They help identify patients for care. They move resources to be able to protect those patients for care, and decisions are made off of the back of that. So I believe that analysts should be professionalised, just like accountants, just like other allied healthcare professionals and scientists within the NHS. And I think that potentially decision makers should go through something similar. What are the ethics of these decision makers? Are they going about it the right way? How would you legislate for poor decision making? And then potentially, to a point that, if it's been seen through some kind of root cause analysis that it was the poor decision made from not getting the evidence, or not reading the evidence in the correct way, or deliberately misreading the evidence to make a decision, what would happen to them? So no, I think that Wes, feels somewhat strongly about this. I haven't read it all, Tom, and you may have read it, but Esther, I'm not sure if you've got anything to add.
So I'm going to take a deliberately apolitical stance on this, but I do think there's a whole piece around empowering the workforce to reflect where we are. So part of the challenge with making good decisions now is that we have so much more information, and we have so much more complexity behind the decisions that we make. We used to have, if I think back 20 years, relatively few inputs on which to make a decision. So therefore, there was a lot of assumption, there was a lot of instinct, there was a lot of gut feel. In many ways, there's less of that now, because we can look so tightly at so many different metrics, so many pieces of analysis and evidence. So I'm fully with you that professionalising the role of those who enable decisions to be made is incredibly important, but also then focusing skills training and support on the people who need to broker those decisions, and often actually introducing an independent third party, and this is not a personal plug, but whoever that may be, to actually act as almost a decision coach when things really matter. So somebody who's not got a vested interest in either direction, but can help make sure that actually good process is followed, that everybody's voices are heard, that you are embracing diverse perspectives, and that you are establishing a shared view on the legitimacy and fairness of what you decide. So making decision quality, I think, to use your term, Andy, higher on the agenda would certainly be a priority.
Can I add something to that, guys, if you don't mind? I was just thinking when you were talking about that, Andy, about the extra accountability. Do you feel that without, and you've sort of mentioned it there in your reply, Esther, that having some support network behind the decision makers to help them, with that extra accountability, do you feel that decision making could stall even? Because as it stands now, there is no repercussions really. If a decision is made and it's a bad one, it could cost millions or even people's lives, but there is no real it's such hidden in the massive bureaucracy of what the NHS is, that pinning blame on one particular person. But if you've got that accountability, people go, yes, it was X, Y, or Z who made that decision, and this is the direct result. So do you worry that it could slow things down or even stall things, or combining that accountability with a system of support?
I think having a rigorous and robust approach to decision making, and again, it has to be done in a timely fashion, shouldn't be stalled just because they have to be rigorous and robust. As you say, these people and people who are directors in the NHS, for those of us who run teams or run integrated care systems, some of the most highly paid people in the public sector, have to make life and death decisions, in theory, of moving resources that will mean that some people get more and some people get less, and they have to make decisions that will move potentially millions of pounds and waste, or use money differently or less effectively than before through opportunity costs. So people need to be accountable for this, and this is what you're paid to do. And I think that there are, and I think then goes back to Esther's point: is there enough support structures within those organisations to help them? And this is why we have lots and lots of sub-directors and deputy directors and associate heads and all of those other people. So there's a whole gang already in there to support them, as well as loads and loads of great analysts who can help provide unbiased information to be able to do the right thing. So I know you do, Phil, but I think it's this idea of. So I think that it's this idea that, as Esther said, having the right support to make it as easy for them to make the highest quality decision. And of course, you can't. Sometimes you have to make a decision where all the data, will not be perfect, or you may not, or you may have incomplete data. But have you had rigorous and robust thinking up to that point to be able to make a sensible decision? So not just then keep kicking the can down the road saying things must be perfect, because nothing will ever be perfect. Esther, the last words.
I think it also comes back to culture, and actually having a culture that embraces learning, and learning when things go badly as well as when things go well is so central to that, Andy. And I think if you know that you've followed a really good process for making a decision, you've embraced perspectives, you've listened, you've applied objectivity criteria, and you've really focused on making sure that you've taken all the evidence into account, then you can stand by the decision that you make. And as a consequence, whether that decision proves to be fruitful or challenging, you can look back at it with a level of confidence and objectivity. And I see the world in general in business certainly evolving far more towards actually this concept of failing fast. And it's far better to make a decision, even if it's a little bit wrong, and then be able to go back and course correct, than it is to be stuck in some kind of status of doing nothing.
Thank you. I think that's the perfect spot to end, unless Tom decides he's going to scupper an early cup of tea again. So I think we'll leave it there. Again,
don't give him a chance, Phil. A huge thank you, Phil. A huge thank you, Esther. I really do appreciate your valuable time. It's been really, really exciting to hear about this in more detail. So thank you very much for your insight.
Well, thank you for inviting me. It's been a pleasure.
Cheers. All the very best.
Thanks, folks. Take care. Bye-bye.